So now we work on the next topic of our semester. Previous lectures were all dedicated to the question how we restore a part of a tooth crown. Even the last lectures, when we have a root remaining which we can restore with a dental post and some construction over it, still mean the condition that someone has all the teeth present. However, the most common pathology of dental origin is partial absence of teeth or partial edentia. And from this lecture and the next lectures, we will talk about the treatment of absence of some teeth in a human being. This semester we talk about how this is reacted with fixed dentures, fixed constructions, somewhat using and similar to the constructions that we talked about already, like inlays, crowns, post constructions, and the removable constructions used for treatment of partial absence of teeth is the question of the next semester. Okay, so let's start. First, we start with the definitions. Some more English words that lots of students don't know at the entering of the university, but need to know to be able to work in our classes. So, what is dentulous? Dentulous is an individual who has his or her natural teeth present. Edentulous, thus, is the individual who has lost his or her natural teeth. So, when we talk about the number of teeth missing or present, people could be maybe partially or completely edentulous. Partial edentulousness and edentulism or edentia is the condition when we see that some teeth in the dental arch in the tooth row are still remaining. Complete edentia means absence of all of the teeth of the human being. So, people were losing teeth from the ancient time, and there was an idea to replace the missing teeth which also exists for a number of years, like the example what you see on the slide. See even in a mummy in ancient Egypt. There was a construction made with gold wire and some extracted teeth to replace the missing two central incisors. Definitely, we don't do these constructions anymore for a number of years already, like several thousand years. But this is an example. Okay, so what are the reasons for tooth loss, or when we talk about nice medical glossary, this is etiology. Etiology are the reasons, the cause of the disease. So etiology of partial edentia for tooth loss is first of all caries. This is more than 1/2 of cases. Next common reason is periodontal disease, leading to the teeth which could be absolutely nice and perfect looking to get loose and fall out subsequently. Third, regular, quite common cause is traumatic injuries or traumas. If periodontal disease is like 45% of cases, trauma takes a couple of percent. It's different in different age. And the rest reasons are quite rare. Still, you need to know that we can see the teeth which were extracted because of cysts, malignancies, and tumors of jaws, radiation therapy for tumors. In a normal case of a jaw excision or extraction because of malignancy, all the teeth of this jaw, even being healthy and nice, are extracted to prevent positive infection of the operation site. Then grossly malaligned teeth are teeth which don't have a chance to erupt in any case. Iatrogenic extraction means the bad work of our colleagues, meaning extraction of a good, healthy, vital teeth. Not nice, but happens rarely, but happens. Congenitally missing teeth, or what we call uh, we also call this edentia. So this is primary edentia, congenitally missing teeth, the teeth which never appeared in their place. There were no germs of these teeth. Or failure to erupt impacted teeth. These teeth appeared in the jaw, but they did not erupt. So these teeth which did not appear or did not erupt are called the cause of primary edentia. The other cases, when the teeth were formed, erupted, came into the dental arch, and then were extracted, are the cases of secondary edentia. Definitely, secondary edentia is most common. Okay, this slide shows us lots of problems associated with the tooth loss. So first what we see is resorption. So we see that when the tooth is extracted, the alveolar bone around the root previously standing there, which we say the socket, is gradually remodeled and decrease in volume. So normally it gets smaller and thinner and takes quite a rounded shape of an edentulous ridge. Usually after the extraction of a tooth, we expect to see the height of the alveolar bone remaining approximately at the level of the place where the apex of the root was, if no measures were taken to prevent this resorption of the socket. So definitely it goes even deeper with time, and this is the reason why immediate implants have more success, as they are usually longer. We have more bone to support the implant if we insert it soon. If we insert it in several years after, then we have a big chance to insert a smaller implant, or not to have bone enough to insert an implant. Okay, these other sequelae, like tilting, drifting, and occlusal disharmony, we'll discuss a bit later. Okay, just to show you the idea what tilting and drifting is. If the tooth is displayed approximately in the same amount as crown and the root, we call it drifting. If the tooth is displaced in a way that we see that the crown goes much more close to the neighboring tooth than the root, this is tilting. Okay, so let me remind you one of the slides from the first lecture. Aims of fixed prosthodontics. One of the aims of our work is maintain health and integrity of dental arch. What is it? When one or several teeth are lost, the neighboring teeth don't stay absolutely same as they were when this tooth was present in the dental arch. We see the deformities of dental arch, and we see that these deformities can cause various problems. Okay. We'll talk about this a little bit later. Okay, definitely when we examine the patient with partial denture, first of all, we have to do the subjective examination, and this is normally done with questioning the patient quite a number of questions. Ideally, this is a health questionnaire, like the example you see on the screen, and the patient is to fill this paper and sign that he told us all the truth. And then we have objective examination. Okay, let me remind you, in subjective examination we have history of disease or anamnesis, chief complaint, which could be coming in these four groups: comfort, function, social, and appearance. Absolutely same as we talked in the second lecture or third lecture. Okay, then we have personal information and medical history. So, and we have also dental history. Let me remind you that medical history was called anamnesis vitae, and in Latin language, and dental history is called anamnesis morbi. When we talk about the dental history, besides to absence of teeth, one is likely to have quite a number of other kinds of dental pathology which is accompanying it. Or this loss of teeth can cause some cases of other diseases which are possibly also for the treatment of this dentist or of the colleague of this dentist. I mean of you. Okay, so what is it about? Dental history requires information about the condition of periodontium of the patient. Then restorative history is the history of which dentures were made before and the result of this treatment. Let me remind you an example. If one says that he's got 3 removable dentures done already and has never worn any of them, then you will not possibly think about making the 4th one, but you will talk about dental implants for making a fixed denture. Endodontic history. If someone says that he has root canal treatment of these 3 molars and all of them were extracted in 5 years because they got abscesses on the roots because of problematic anatomy, like the treatment was not successful, although it was done by good dentists before, you would think about doing some construction which does not require root canal treatment as a preparation for the prosthetic treatment. Orthodontic history means previous orthodontic treatment or attempts to do it. Removable prosthodontic history is a part of restorative history. Okay, oral surgical history. Okay, this is experience in extraction of teeth. Radiographic history, which x-rays were taken, what was found in them. And TMJ dysfunction history. This is to distinguish the patients which are 100 times more problematic in treatment than a common dental patient. Okay, so then if we recall the basic examination, in case of partial denture, we also start with inspection. We had extraoral examination and so on. Now we look in the oral cavity. So the dentist of the kind that you are listening to, a prosthodontist, starts the examination of oral cavity from the teeth. We look for teeth, then we look for dental arches or tooth rows, then we will check occlusion. Only after this we examine periodontium and also soft tissues. So, if we look to dental arches, we definitely can check the anatomy of them. and check the number of teeth, and in partial edentia we see some teeth which are still in there and some teeth which are not present in the oral cavity. Secondly, we look for occlusion. We ask the patient to bite together and check this in any case of treatment which requires our help, because occlusion is that's our part of business, of dental business. Therapeutic dentist can restore occlusion sometimes in a single tooth or a couple of teeth, but a prosthodontist is the specialist who deals with a big part of a dental arch. We could have bridges or other kinds of dentures which replace all the missing teeth or change the occlusal contacts of all the teeth or group of teeth. So occlusion is a must to be checked by prosthodontist. So when we look at the dental arches, we specify the kind of pathology of partial edentia or partial edentulation according to classification, as any condition of this specific patient is an individual condition, but still to be able to talk to each other, we need to understand each other. And classification is what helps us to understand. So the Kennedy classification is what you see on the slide, was suggested by American Dr. Edward Kennedy in 1925. And this is the most commonly used in the world classification of partial edentia. And this is what you need to know, because this classification is used by the dentists all over the world. And this classification is what you are supposed to know by heart. You will find it in any textbook of prosthodontia, which includes information of treatment of partial edentia. So you see the description. Actually, we think that the student should know this classification by heart, so I will not even read it for you. You can look on the slide, you can look in the book. Okay, so we go further. And this slide helps you to understand the prevalence of different types of defects of dental arch of tooth row. Okay, incidence of occurrence or prevalence. Anyhow, this is also an example to explain classes. And additionally to classes, Dr. Kennedy suggested the subdivisions. So we say class in in our translation, or sometimes you can hear this in Europe. Dr. Kennedy talked about types or divisions. Anyhow, we have also some rules how to use the Kennedy method, which were suggested by Dr. Applegate. Okay, coming a little bit back, let me remind you that we have classes or types by Kennedy, but there are also subtypes of subdivisions, and they include the additional defects in the dental arch. Anyhow, in Kennedy's classification, the main idea is coming from the most complicated conditions described by type 1, by bilateral defects with missing teeth, having no distal support, no teeth present in distal part of dentition, up to the fourth class, which is the only class which has no subdivisions. Okay, but you can understand it quite easily just from reading. But to specify some conditions, we have subdivisions. And to make the use of classification more practical, Dr. Applegate suggested some rules. So, classification should follow rather than precede any extractions of teeth that might alter the original classification. If some teeth are to be extracted, we don't count on them when we set the type of defect. Okay, if a third molar is missing and is not to be replaced, we don't replace third molar normally. It is not considered in the classification. But if it is present and is to be used as an abutment, it is considered in the classification. Okay, same about absence of second molar. So if it is missing, it is not to be replaced. Usually we don't replace it if the only option is a partial removable denture. So this second molar is not considered in the classification. So the idea is that normally nobody would agree to be using the partial removable denture, which is quite a big and uncomfortable denture, to replace just missing second molar on one side. So then next rule is that the most posterior edentulous area or areas always determines the classification. On the other, in other words, if we have combination of defects in front and in back, we'll look for defect which in back, and it will determine the class of the classification. We'll just call it subdivision or modification. Then rule 6 is just about it. That's what I mentioned. This additional edentulous area is referred as modification, and we count them by their number. So if we have defect of class 1 and also two defects which are included in the between the remaining teeth, this will be class 1 subdivision 2, modification 2, sorry. Okay, then rule 7 is that we count not the number or the length of the defect, but the number of these defects. And in rule 8, is that class 4 is the only class which has no modification areas. Okay, so this was suggested by Applegate, and you also need to know it. However, the other classifications also existed, and one of the classifications that we are asking you about, because it's used widely on the territory of previously existing Soviet Union, was suggested by Professor Gavrilov, who was teaching in Smolensk Medical Academy for a long number of years. So, according to Professor Gavrilov, class 1 are distal end edentulous areas, or distal end defects, unilateral or bilateral. These are the examples shown by these Russian A and B and B. Class 2 are edentulous areas which are included in the tooth row in the dental arch, front and back portions. So these are all the examples shown under the letters V, G, D. Class 3 are combination defects, means the condition when there is a distal end edentulous area and also an defect which is included within the dental arch, like the example shown by the letter E. And class 4 is the single remaining in the jaw tooth. This is an example shown under the letter G, and this is to specify the condition which is quite different from a regular edentulous condition, as in this case, with just one tooth remaining, we usually have to do the partial removable denture in the procedure that we do the complete removable denture. And this is a more complicated procedure, and this is a different protocol. Okay, so some more English words that each student should know from now on. So, edentulous ridge is the piece of alveolar bone with the mucosa over it in the place where the tooth was previously standing and was extracted, or did not erupt in place, and we have a gap in the tooth row in the dental arch. Then we have abutment teeth. These are the teeth which will carry the load of the replacing the missing tooth. Then this construction, which is a fixed construction, and it is fixed with some retainers which are put on the abutment teeth, is called a dental bridge in simple words, or fixed partial denture, FPD, in nice English. However, we used to say bridge quite a lot, so sorry, but I will use this word quite a lot instead of FPD, of fixed partial denture. Anyhow, in the bridge we have retainer, which is a extracoronal restoration cemented to prepare the abutment tooth. So, abutment tooth, it carries retainer. Retainer could be a crown, like full crown, it could be a 3/4 crown, it could be an inlay or some post construction, but this all is in or on the abutment tooth. Then the artificial tooth, which is replacing the missing one, is suspended from abutment teeth, is called pontic. So this is what is actually the aim of a bridge is. Okay, then we also have connectors. Connector is rigid or non-rigid joint connection between the pontic and the retainer. So this is also important to know. So retainer, connectors and pontic are parts of a bridge, and the bridge is sitting on abutments. Okay, so what are the sequelae of the dental loss once again? What happens if the teeth of the patient were extracted partially? Some of them were extracted. So this is also what we call the clinical symptoms of partial edentulism. So the dental arch tooth row is split into functional and non-functional groups. The teeth which have the teeth opposing them and which are coming to function, like these ones and these ones and these ones, are making functional groups, and the teeth which don't have the teeth against them, which we also refer to as antagonists, these teeth make non-functional groups. So even there is quite a number of teeth in the dental arch present, but there's some gaps in the dental arch against lots of teeth are taken out of function. Thus, this decrease in the number of occluding pairs leads to overload of the teeth of functional group. So if these just 3 pairs, 2 pairs, and 2 more pairs make 7, chew instead of 16 pairs which should be chewing normally in this patient, they will get twice more load than the normal teeth get. And this overload could be possible reason for periodontal disease and tooth wear. This is not happening in the day next after the extraction of teeth. because each teeth and tooth has some functional reserve that we'll talk about later when we describe odontoparodontogram. But this happens in some time, and this is a very possible outcome. Either they will wear their enamel if the muscles work mostly against periodontium, or against periodontium which is strong, or the teeth will get loose and because of periodontal problem if the periodontium is the weak chain and if enamel is stronger. So we talked about resorption previously, so this is to be taken into consideration when we discuss implant therapy most. But we also see the changing of position of teeth in the dental arch, and this happens also because of the teeth which are extracted next to the remaining ones. So tilting and drifting, these are change of position of the tooth. Definitely drifting is much better, but unfortunately it happens only in the early age. And occlusal disharmony, which happens because of the change of position of the teeth, this leads to discomfort, pain and damage in temporomandibular joints. Let's have a look in this picture once again. So we see we'll see tilting and drifting of both molars in the one in the upper jaw and one in the lower jaw. And we can suppose that the tooth in the upper jaw was starting its move earlier than the lower one, because we see most of the tooth in almost proper position in the upper jaw. So this was mostly drifting, just a little bit of tilting. In the tooth in the lower jaw, we'll see mostly tilting. This is what happens after the growth of the jaw stops. And you need to know this. What's the age when the growth of mandible stops in a human being? That's quite an early age. So from this age, the teeth are likely to get tilting. And what is bad about it? What is bad about this secondary deformity? First of all, the tilt of teeth leaves gaps between this tooth and the neighboring one. So we'll have food which traps in between the teeth, and this irritates the gingival tissues. This causes inflammation of the gingival tissues. This inflammation goes on to the periodontal ligament and the bone that the tooth is standing in. And then we have loss of bone around the tooth which changed its position. Secondly, the optimum for receiving the occlusal load for the tooth is to get it along its long axis. In case of tilt and drift, the tooth is likely to get more load because it's, so sorry to say in simple words, it's not standing straight against the occlusal load. Then we'll also see some other deformities of the dental arch, which can also include displacement of the tooth in vertical plane. Okay, so all these deformities of dental arch of a tooth row are called secondary deformities. Primary deformities happened because, like other kinds of orthodontic pathology, because the jaw did not grow properly or the teeth were erupted to a wrong position. And secondary deformity means that the teeth were erupted to proper position and the occlusal contacts were normal, but then because some teeth were lost, the teeth neighboring to them or being against them changed their position. So what do we see as a secondary deformity? Most common one is coming in vertical plane, and we call it over eruption or Popov-Godon phenomenon. We see the tooth which gets taller or longer than the neighboring teeth and then the normal position of the occlusal surface of this tooth. Sometimes the tooth is erupted in the way that it looks like the tooth is coming out of the bone, like in this picture. Sometimes we see the tooth which is coming together with its periodontium and bone. So this makes the treatment even more complicated in many cases. So Popov-Godon phenomenon, we'll talk about it soon, is the most common kind of displacement, and this comes in vertical plane. The next plane is sagittal plane. This plane, from back to the front. In this plane we'll see tilting and drifting. This is the next common in occurrence kind of displacement. And third one is displacement in transversal plane. Transversal plane is from left to right. So in this plane we distinguish oral or vestibular tilt of the teeth. However, as this bone is much stronger than the bone in other planes, the displacements in transversal plane are seen rarely. And we can have a combination of deformity like the rotational change of position of the tooth. So now about Popov-Godon phenomenon. This condition was actually known from ancient times. This displacement of teeth in the dental arch in vertical plane associated with extraction of some teeth against them, their antagonists. Anyhow, Russian scientist Popov, who was not a dentist, described in 1880 in Scientific Journal and results of experimental study in guinea pigs after extraction of several teeth showing displacement of adjacent teeth. And in 1905, Dr. Charles Godon suggested the theory of articulation balance. This is quite a primitive and mechanical theory. However, well, definitely we cannot treat it seriously nowadays, but it helped the dentists at that condition of the dental science to understand the idea of articulation balance. What is it? That this is that periodontium and bone of each tooth means gets the loads from both sides in sagittal plane and in vertical as well. So we have force coming from the antagonist and the force of growth of periodontium which is meeting and opposing it. We see the pressure on the contact point of each tooth standing in the dental arch from the neighboring teeth. This is also coming from chewing and biting on the teeth. And the occlusal load is spread along the dental arch from the contact points of the neighboring teeth and the ligaments, periodontal ligaments, which connect periodontium of the neighboring teeth. So if one of the tooth is lost, the result of this parallelogram of forces makes the tooth to erupt. These sagittal plane forces are still balanced, but the force coming from the growth of periodontium makes the tooth come out of the dental arch and become taller. If the tooth is standing next to the defect in the dental arch, the forces coming from the opposing tooth and the growth of periodontium of this tooth are balanced, but the pressure in the dental arch of the same tooth now is prevailing from the side of the tooth which is in contact with the contact point with this tooth. And this force is lost, so we see the change of position as a result of the change of the force. So, this first theory, which was quite primitive and mechanical, still helped many dentists to figure out the results of practical work which we see in the case of someone is going without replacement of some missing teeth. Okay, so next effect of partial edentia is associated with the problems of temporomandibular joint. First of all, the teeth which are displaced in a way that was described previously as Popov-Godon phenomenon will make an articulation block. What is it? The picture on the slide explains you that the tooth which has displaced in vertical plane can come in contact, normal, regular contact with the teeth of opposing jaw only in just vertical closing movements. However, as you studied in general dentistry, most of the movements of the mandible in chewing, biting, include not just vertical movements, but also some part of transversal or sagittal movement. So the jaw is not coming up and down, it moves sideways together with this. So this is the condition that the tooth hits the opposing dentition not together with the other teeth of the occlusal plane, but there is some points of contact that all the force of occlusal muscles get on the contact of just one pair of antagonists. Definitely, this leads to the risk of overload. In other conditions which can accompany this, we can see that the patient starts to avoid making some of the movements which cause this increased load on the tooth without just even noticing it. And this results in the condition that some movements of the jaw are used less than genetically predisposed, and some movements of the jaw are done more frequently. So this change in the normal movement of the mandible, in the amount of movements done, results in the condition of masticatory muscles. So this is in the same verse. Articulation blocks during lateral and frontal excursions of the mandible prevent normal range and amount of movements, thus reacting in the condition of muscles which move the mandible. This can change the position of the elements of TNG. But to prevent this condition, sometimes our patient finds a different position of mandible, which is different from normal position, but at this position there's no this excessive contacts of teeth. So we get habitual displacement of TMG elements, and this is usually accompanied with pain and extraneous sounds like clicks in movements of the mandible in the joint. So the slide shows you we can check the position of the condyle, the head of mandible in the joint, sometimes with OPG. Sometimes we have the machines which can show us the joint, but nowadays we have a better instrument which is a 3D imaging like cone beam CAT scan, and this helps us to see the real position of condyle in the joint and even to do the measurements. So I suppose you know which of the condyles is standing in the joint in a proper position and which one is not. This is up to you to guess the result or ask your teachers in the practical classes. So, okay. One more problem with the TMG, which comes as an effect of partial indenture, is usually associated with a condition when almost all back teeth are missing. So, when they are missing, then all the occlusal pressure is transmitted through the periodontium to facial bones. And when the teeth are present, the occlusal load is coming from the periodontium of teeth to this special oriented alveolar structures and also the bones like maxilla and mandible called counterforces. Okay, but when just front teeth are present like in this condition, all the movements, all the occlusal load are the loads which are sent to the TMG structures. So we also get a risk of overload of TMG structures because the occlusal loads are not coming to the molars, which have these special counterforces which are to fight with the occlusal load. Okay. Then, when the teeth which keep the normal vertical dimension of occlusion VDO are missing, we are likely to see the change of position of mandible to the skull, because the front teeth, let me show it in this picture, don't have a possibility to give a stable position of the mandible against maxilla. All the front teeth, like incisors, don't have cusps coming in cusp to cusp contact, and they work like a sliding plane. So the lower teeth are likely to slide deeper and more distally, more posterior from the normal position when the jaws are coming together. Definitely this happens not in one closing, not in a day, and not even in a month. But this is likely to happen in a patient who is going without replacing teeth for years. So, this displacement of mandible is associated with the same displacement of condyle in TMG. If the jaw is displaced vertically it's more up than it should be, and it's displaced more distally, more posterior than it should be, same happens to the position of condyle in the joint. Head of mandible is also displacing more vertically and more distally. And the distal part of the joint does not have any bony support. It's just a capsule of TMG. So it cannot hold it. And besides to the condition that the muscles work in not proper height, so they work ineffectively and also can work with pain. Besides to the clicking in the joint, we can also see the jamming of the capsule of the TMG and the chorda tympani nerve, which is coming in fissura petrotympanica behind it. So this condition associated with the distalization of the mandible, like you see in this picture, is coming together with the decrease of vertical dimension of occlusion. And this picture shows you the normal position of condyle in the joint and the displacement of the condyle, the head of mandible, distally. So we can jam the nerve, and this causes neurologic deficit in the areas of innervation done by this nerve. So the result of this is pain and clixum TMG, the change of salivation and paresthesia like burning feeling in the tongue, throat and side of nose sensitivity, and pain as well in the structures around the joint ear, because we are also near this anatomical structure. So we can have also hearing impairment and some other symptoms. So this syndrome was first described by Castaing, and thus we talk about Castaign's syndrome as a neurologic syndrome, which is, however, treated not by neurologist but by prosthodontist. Prosthodontist needs to restore the proper position of mandible and the height of occlusion, which will result in not jamming the nerve chorda tympani and thus decrease and missing of the symptoms of this syndrome. Okay, so now we are to talk about preparation of the oral cavity to fixed prosthetics. What is this? Preparation of the oral cavity includes definitely examination of the patient, setting diagnosis, selection of a treatment plan. We can use different additional methods that you see on the screen. And after this, the treatment plan of prosthetic treatment is usually not to start from the very beginning, as we are to do some procedures of mouth preparation for prosthodontic treatment. This means that we need some dental treatment to be done before we can start real prosthetic treatment. All these procedures are divided into two big groups. First are sanitation procedures, and the second ones are procedures for the purpose of prosthetic optimization. Sanitation procedures means that this is the dental treatment which is to be done in general to the patient just to improve his or her oral health. I suppose you know already that many people around you in society are going without having complete order in the oral cavity. However, the basic rule for prosthodontic treatment is that this is the final element of the complex treatment of the oral cavity. So, if the patient comes to us to make a crown or a bridge, we will not start doing this until the teeth of the patient are clean. And same is also done by different other methods which are performed by therapeutic dentist, oral surgeon, periodontologist, and some other specialists. Second group, procedures for the purpose of prosthetic optimization, means some kinds of dental treatment which are not necessary for the patient in general, but the patient needs them in some kinds of our plan of prosthetic treatment, like if we want to make a porcelain fused to metal bridge, but in diagnostics we see that the pulp is that close to the surface of the tooth that we will break in the pulp in preparing the tooth, we would prefer to do the root canal treatment and remove the pulp and seal the root canal before we start this preparation. Same, if someone has a bone of the jaw which is quite rough, but this does not disturb the patient normally, we would think about making this bone smooth in surgical operation only in case that we plan a partial removable denture or complete removable denture sitting on this alveolar ridge. So this is to make the difference. Okay. In other classification, we can talk about mouth preparation in prosthodontic procedures and non-prosthodontic procedures. This is to describe who is doing this. Sometimes a general dentist is doing all kinds of dental treatment by himself or herself. Sometimes the general dentist is to share the work with other specialists, like oral surgeons, orthodontists, periodontists, and so on. That's why this classification is about how we share the preparation. So, anyhow, which help of other specialists can we get in preparing the patient's oral cavity for prosthodontic treatment? This could be urgent treatment of non-acute problems. Conservative dentistry or therapeutic dentistry can mean proper oral hygiene instruction adequately implemented at home. So, to teach the patient to brush teeth finally. Replacement of defective restorations and removal of carious lesions. Bad fillings, carious lesions, also recontouring of over-contoured crowns, okay, or reshaping, improving the shape of the teeth which are antagonists of our future crowns and bridges. Endodontics, root canal treatment in case that we need it, in case that we are afraid to damage the pulp of the tooth in preparing this tooth for an artificial crown. Treatment of oral mucosa diseases, especially in the place which will be after this our prosthetic bed. Okay, this slide is also an example of some pre-prosthetic procedures. So, to mention from it, we talk about conditioning of abused and irritated tissue, which means that if there is any inflammation of oral mucosa or periodontal tissues, this should be treated before our treatment, as well as periodontal therapy is to be done. And also we should mention splinting of weakened teeth, which is done periodontist, and this person is usually a therapeutic dentist in our country. Okay. Another classification talks about of relief of pain and infection and any other acute conditions. All the prosthetic treatment can start only after this is corrected. So this help is received from therapeutic dentist, but possibly from oral surgeon as well. Okay. Gingival disease, help of periodontist. Conditioning of abused and irritated tissues. This is more for the removable dentures. However, we also mention this as we won't come back to this preparing of oral cavity in next semester again. So you will use this information for the next semester as well. Okay, then what can we get as a help from oral surgeon? First of all, this is to extract the bad teeth and roots. And definitely we should take into consideration that healing of sockets is usually quite a long procedure. Normally, we need to wait about a month for fixed denture making and about 2 months for removable denture making to let the alveolar ridge heal in the proper volume. So, extraction of teeth is usually supposed to be done as early as possible, possibly even before the conservative treatment by therapeutic dentist. Then, another kind of oral surgery help is pre-prosthetic dental surgery. This is their help for us to make a proper denture. What kind of help can we get from them? Alveolar ridge plasty, increase or decrease of alveolar ridges, correction the shape of alveolar ridges. Periodontal surgery. Sometimes periodontist is a therapeutic surgeon. Sometimes this periodontal surgery is done by oral surgeon, like pocket elimination, mucogingival procedure, guided tissue regeneration, or root resection. All this is done before our treatment, because if we make a denture before the oral surgery, after the oral surgery this denture is likely to be replaced. Okay, removal of residual roots. This is just a picture. Extraction of impacted teeth. If we make a crown on such a tooth and then impacted tooth is extracted, the fit of the crown is likely not to be proper in the part of this tooth, because we will have some resorption of the bone after impaction and the change of the level of the gum. Okay, so extraction of teeth and residual roots. So this is the residual root. If we make a removable denture in this case, this root, which was in bone for many years, because of the pressure of the denture base of partial removable denture, will erupt, and then we will have to extract it, and then the denture won't fit and we'll have to remake the denture. Impacted teeth are teeth which are in bone. They can also erupt after the denture is made, or they can damage the roots of the teeth, which are abutment of our bridges, and many other conditions. Hyperplastic tissue. So this could be some shape of soft tissue which is excessive compared to normal condition of these tissues. So you can read this. This is mostly for removable denture making. We cannot set a denture base on such excessive tissue, so we won't make a denture which will be satisfactory for the patient. Okay, what else do we have? Bone cyst or exostosis. Exostosis is an excessive growth of bone on the surface of alveolar ridge. Most commonly, exostoses are met in mandible, in the oral surface, in the near the premolars, and they are also referred to as mandibular tori, and in the palate, in the mid-suture. See, this is palatal tori, and definitely if we are to make a partial removable denture, we won't be able to come behind this torus or in front of it. We'll have to place the denture base over this torus, and these palatal tori are usually covered with a mucosa which is in unsatisfactory condition, and the denture base pressure on these mucosa causes the constant inflammation and pain under the denture base. So we won't be able to make a removable denture until this torus is removed. Lingual tori or mandibular tori is what is exostosis in mandible. Also problematic to do the partial removable denture. So we can displace the not good muscle and frenal attachments. And finally, let's talk about the occlusal correction. When we make fixed partial dentures, bridges, we are working with people, some of them are coming to us not right after the extraction of teeth and healing the sockets, but they were going for a number of years. And we have the loss of arch integrity and secondary deformities with displacement of teeth. And we are to correct all this, because if we do not, we won't be able to do a denture which is functioning properly. So this is also slides which show you different examples of deformities of dental arch, like Popov-Gadon phenomenon, which you see in these molars, in this molar and this premolar, or also molars and premolars of the lower jaw coming closer towards the part where the teeth are missing in the upper jaw. We can see also transversal change, same as here. So the teeth which moved more lingually, and this is also a problem to prepare them for crowns or retainers of a fixed partial denture, or to bring them into proper occlusion. Okay, this is a slide which you can see in some of our textbooks done by our chair. So this is a noticeable Popov-Gadon phenomenon. But please note that if we continue the occlusal plane, we'll see that the neck of this molar is at the level of occlusal plane. So even if this tooth is extracted with just a simple extraction, we will have the bone remaining at the level of occlusal plane, and there will be no space for the teeth. So this Popov-Gadon phenomenon is occurring quite a lot of time as the growth of periodontal bone at the base of alveolar ridge, and thus not the height of the crowns is increased, but the height of alveolar ridge. Thus, in this case, we would need to ask the oral surgeon not just to extract these teeth, but also to cut a piece of alveolar bone to leave the space to place the teeth which are coming to the other replaced teeth in normal occlusion. A smaller but also not very pleasant sequence of the displacement of teeth means that to make these two teeth parallel to each other, as we need in abutments of a bridge, we will have to cut the tooth which is in tilt more. We likely to do the root canal treatment on such a tooth before. And secondly, to place the tooth in a proper, to place the bridge to a proper position, we will have also to cut the equator on the neighboring tooth, which is also in a tilt. So this means that we will have to cut the enamel of the tooth which is standing near, and we will have to explain the patient why do we have to cut the healthy tooth which is not used in our bridge. So, how can we prepare the oral cavity of the patient? Speaking of occlusal adjustment, we can have orthodontic treatment and we can use various prosthodontic measures. So, if the tooth is displaced in a small amount of volume, like about 1 millimeter, we can use the simplest way that we use. Namely, we can just grind the tooth to the volume of its displacement. This is not met with pleasure by our patients. We always have to explain to the patients why do we have to cut the healthy teeth which are not our abutments but standing against them or standing against the pontic of the bridge. But we need to do this and we need to explain the patient that this is actually what should be done as a must. And this is actually the result. Our work is the result. The patient was going without teeth for a long time. But now we are not able to do anything unless we cut these healthy teeth. Anyhow, if the amount of tooth to be cut is about 1 millimeter, this is usually done without any further correction, as the height of enamel on the occlusal surface is somewhat like 2–2.5 millimeters. So even if we cut half of it, there is no problems with sensitivity or upcoming caries. In case that we are to cut more, we are likely to cut the tooth and then to prepare it for a crown additionally. So we have to cover the tooth which is displaced with an artificial crown. In case that we open the dentin, then we'll have to cut it for the volume of displacement and also to cut it for the volume of the crown and make it in a proper position with the help of this crown. However, if we are not able to shorten the tooth for this amount, or we are afraid to break in the pulp, or we have a big growth of bone, an alternative for this treatment is a orthodontic treatment. This construction is used as an orthodontic appliance, however, it's usually done by prosthodontist. This is like a stamp soldered bridge, just the pontic is made as a framework made of metal soldered to the crowns. Usually these teeth which are not abutments yet, they will be abutments for the future bridge. However, usually for stamp crowns which require minimal preparation, there is a chance not to cut them yet. But we are using this framework to support the acrylic resin, and we do the pontic with acrylic resin attached to this framework, and we make the increase of occlusion against the displaced tooth. That only this tooth is coming in occlusion and the other teeth are not coming together for 2 to 4 millimeters normally. This disocclusion should be less than the physiologic gap which we see between upper and lower teeth normally in normal occlusion. So this increased force coming from occlusal muscles result in the changes in periodontium of displaced tooth, and we see the opposite direction change of position of displaced tooth, so it's like returns to its original place. When the other teeth are coming in occlusion, because of this development of positive process, we can add some more acrylics to the occlusal surface and make a new 2 to 4 millimeters disocclusion condition in case that we need to have bigger displacement in treatment of the problem. So finally, when we finished our treatment and the displaced tooth is now in proper position, we can take off the temporary orthodontic bridge and make a permanent bridge which will contact the tooth now in proper position. Okay, this is about preparation. Then the crown coping means sometimes within the endodontics means that sometimes in case of excessive preparation of the tooth for a crown, in case of displacement, we will also require a root canal treatment for such a tooth, which should be done before we start this preparation. Extraction done by oral surgeon is also an option in case that the displacement is big and the tooth is of no sense to be saved, or in case of big displacement which could not be corrected by orthodontic treatment. And let me remind you that we need to ask and remind the oral surgeon to remove part of bone which appeared because of this displacement, to make space for the teeth of the future denture. Okay, this is also an example slide. It shows also an example of surgical help done for the severe case of displacement. Teeth are also at the level of the occlusal plane, and these are all 3 molars of the upper jaw. So we can do even a big surgical operation, which is definitely done by maxillofacial surgeon, not oral surgeon. It is done in the hospital. So this is maxillary segmental osteotomy. And this means that a piece of bone together with the teeth is cut out. The part of bone at the base of it is removed, and then this block with teeth is brought to this new place and attached there. Thus, the block of teeth with periodontium is placed to proper position, and this gives us a possibility to do the new denture with teeth in mandible, and they will come with these maxillary teeth in proper occlusal contacts. However, this is a big severe operation, and this is done quite rarely, but you need to know that there is such a chance to meet. Okay, so all these methods help us to prepare the oral cavity to do the denture, which will be functioning and serving to the best of the health of the patient. Next 2 lectures will talk about the clinical and laboratory procedures of making fixed partial dentures, which are bridges. Thank you and goodbye.